Thanks so much, Karen. Thanks for the invitation. It's a real pleasure to be here. My name is David. I'm a neurologist from Sheffield. These are my disclosures. Today, I'd like to take you through a couple of things. We'll talk about progressive MS and how you might recognize progression in your patients. Having discovered or having suspected that your patients might be progressing, we'll talk about actually what's leading to that and how we can talk to patients about that and help them rationalize what they're experiencing. There's no point making a diagnosis if there's nothing that you're going to do about it, so we'll talk about how you might respond to the fact that someone's progressing, and we'll talk about drugs and other things that we can do to help people with progressive multiple sclerosis. Actually, the nature of what progressive multiple sclerosis is changing with some modern developments. So I'll take you through some of the modern thinking about actually when progression starts and what it causes it that challenges some of our previous paradigms that we use to talk about multiple sclerosis. We've got loads of time for questions, but if there's time, what we'll do is we'll flex our new skills. I've arranged to have a video of a patient talking about his experience, and we can work out what we think is going on with him and what we're going to do. So let's talk about recognizing progression in your patient. So this is an illustrative case. We'll call her Lisa. So Lisa's 45 years old. She's a professor of statistics at the university. So she likes numbers, she likes percentages. She doesn't like woolliness. She wants exact numbers. And she was diagnosed with multiple sclerosis 15 years ago. This is what happened to Lisa. So she had an episode of optic neuritis. Oops, it's going through its own accord. Oh, dear. Oh, dear. See, it's spoiling everything. Oh dear, it's... Can you help? Ladies and gentlemen, that's all you need to know. That's all you need to know. I think it's working now. So she is 45. Oh, it's still going a bit fast. It's still going on its own. If you do, click off use timings, please. It's all right now. Oh, there we go. So at a slightly slower speed for those people who didn't catch it. If you didn't catch it the first time round, this is Lisa. So she had optic neuritis 15 years ago. At the time, we told her to go away and see if anything else happens with some MS nurse support. And unfortunately, the next year, she had a bad relapse that affected her spinal cord. For a period of time, she was only able to walk with a stick. We gave her some steroids, and she was commenced upon Avonex, which was standard of care at the time. And every year since, she's been reviewed in clinic, and actually is doing pretty well. She seems fairly stable, so she comes to see you. This is your last patient of the morning before you can go to lunch, and you say, well, Lisa, how are you? And this is what she says: look, I'm brilliant, thanks. The medicine is great. I haven't had a relapse for such a long time. I was having a relapse every year, you'll remember. My walking's great. I've thrown that stick away. Haven't had to use it again. So what do we think about that? Sounds good. Sounds good. So yeah, you're really hungry. You say, phew, great, lunchtime for me. See you next year. So you go to lunch. A hospital canteen in Sheffield's got a very special table with a candle. Lisa drives in a small car home, and everyone's happy. But yeah, let's go back and let's sort of just explore a different scenario where we just reflect things back to Lisa and say, well, that's good to hear you haven't had a relapse, but are things exactly the same? And this is what Lisa says. Well, I suppose my walking isn't quite as good as it was, although it's pretty hard to tell. Maybe it's a bit harder to concentrate. I wasn't that great at it anyway, but it could be a bit harder. Do patients ever tell you this? And what do you do? It's tricky, isn't it? They always say the worst. They always say the worst. But let's try and just quantify exactly what Lisa means. So one thing I find to be quite helpful, it's really hard to ask people how far they walk. They almost never tell you. They say, I don't walk that far. But one thing I find quite helpful is actually to ask people about their holidays. So we take Lisa this holiday, and she went to this hotel, and she went to this oyster place on the seaside. And she walked there, and she sort of said, well, yeah, I walk there every day. I get there, I'd be really, really tired. I wouldn't be able to walk a step. I'd have like 10 oysters, 2 glasses of champagne, and then get a taxi back. We say, well, look, thanks, Lisa. You know, how were things, say, if we take you back a couple of years ago, I went to Barcelona. I stayed at this hotel here. I walked all the way down the beach, and we plotted it out. It's about 2 miles. So she's gone from being able to walk 2 miles to about 500 meters within 2 years. Cognition's really tricky to get a feel for. I sometimes ask people about work and their hobbies. Lisa used to do the crossword, and she'd do it between her lectures. And she used to find a couple of years ago that she would always finish it. Now she can do about a third of that. So what do we think about that? Suspicious that something's progressing, aren't we? We're suspicious that something's progressing, and she hasn't had any relapses. So secondary progressive multiple sclerosis is a funny old entity. So with relapsing remitting multiple sclerosis and primary progressive multiple sclerosis, there are these really clear rules and flowcharts to help you with the diagnosis. And you need a bit of experience and knowledge to be able to operationalize these rules. But once you can operationalize them, most clinicians would agree when someone had relapsing multiple sclerosis or someone had progressive multiple sclerosis. Secondary progressive multiple sclerosis is much murkier, and even the language that people use to talk about it is murkier. So these are the 2 sort of papers that talk about defining progressive multiple sclerosis. And they sort of say you have to have a progressive disease course, steadily increasing, objectively documented neurological disability, independent of relapses. All of that sounds fairly clear, but they make it lots harder. They say fluctuations, period of stability, superimposed relapses are allowed. And the second paper says that there's no clear clinical, imaging, immunological, or pathological criteria to determine the transition point. So it's really hard, isn't it? It's really murky. No one tells you at what point someone develops secondary progressive multiple sclerosis. And this is another attempt to operationalize things that's even harder, I think. But it asks us at every point that we see the patient to consider whether the MS is active, either radiologically or relapses, or whether they're progressing, whether things are gradually changing from the neurological disability. And of course, I don't need to tell you all of this, but MS isn't just a disease of walking. It affects all these domains and others, and you can progress in all of those. So you can progress in upper limb function, cognition, fatigue, vision, ataxia, pain, and all the other symptoms that multiple sclerosis can cause. This is hard enough when we used to be able to physically see our patients and get them to walk certain distances and test their strength. But I think the modern paradigm where we do lots of our visits remotely challenges us even more to make early diagnoses. So my point's about recognizing progression in your patients. It is quite hard to detect. I found that you need to ask your questions in a different way. Patients are so used to coming to clinic and being quizzed about specific relapses that they often neglect to tell you about slower things that have happened in their life, and sometimes asking the questions in a different way, or sometimes just being, you're all incredibly good at this, just being interested in patients and their experience and their hobbies can be helpful. It does mean that we have to think about multiple sclerosis in a slightly different way. And progression isn't just related to walking. That's the most easily objectified symptom of multiple sclerosis. But any symptom of multiple sclerosis can objectively worsen with time. Any questions about that? Or there's time at the end if you want to save your questions to the end. Let's wait to the end. So understanding what causes progression. So we'll go back to Lisa. So we explore things with Lisa and say, well, look, on the basis of what you've let me know, I am suspicious that your multiple sclerosis is just starting to progress, and that's the reason that you've noticed those difficulties with your walking. That's the reason that you've noticed those difficulties with your cognition. And there's other things that I'll do to look into that and make sure that nothing else is causing that. But I am suspicious that that's the case. And we worked Lisa up. She has some blood tests. They don't show any other cause to explain these symptoms. And she has another set of MRI scans, which are unchanged from scans a couple of years beforehand. And Lisa says, well, look, you know, you're telling me that things are getting worse, but at the same time, you're telling me that my MRI scan is exactly the same. What's going on and what's happening in my brain? So, what did you say, Sarah?
I think it's outside.
Oh, was it? Oh, right. So this is sort of my simplistic understanding of what happens in multiple sclerosis. You have these activated cells in your immune system that are autoreactive towards your brain. They get activated and they form these aggregates in your brains of inflammation. And they all aggregate together, CD8, CD4, B cells, Th17 macrophages, and they form these little aggregates of inflammation. And in these areas of inflammation, there's demyelination and there's axonal damage. And you can see these on an MRI scan, and when they're brand new, they enhance with contrast, and they tend to stay in that place for a period of time. And when they affect certain tracts, they cause symptoms relevant to those tracts not working. So when they affect your nerve to your eye doesn't work, you can't see. When they affect your cerebral hemispheres, you get cognitive changes, visual field loss, hemiplegia. They cause all these complex eye movement disorders and unsteadiness. When they affect your brainstem, and when they affect your spinal cord, they can cause difficulty with your walking, your bladder, bowel, and some sexual difficulties. And that is true for the early stages of multiple sclerosis, and that's what happens in the early stages. But in the later stages of multiple sclerosis, MS slightly changes. Relapses are much less prominent, and actually the thing that drives progression is a gradual loss of axons within the brain and spinal cord. And this is just how bad it is. So this is a paper looking at the spinal cords of people who are well and with progressive MS. So that's the spinal cord, the cross-section of a spinal cord in someone who's well. All of those little brown things are distinct little nerves going down the spinal cord. And this is the spinal cord of someone with multiple sclerosis. So you can see there's about a 70% reduction in the number of nerves going down their spinal cords. That's why their legs don't work properly. That's why they have bladder, bowel, and sensory symptoms in their legs. Exactly what leads to this gradual nerve death hasn't really been worked out, and there's lots of competing theories. And actually, probably all of these theories are true to some extent. Nerves that are inflamed, that are damaged with inflammation, can gradually die over time because the damage that they've sustained is enough. They can live for a short period of time, but they then die. And actually, some different forms of inflammation that are within the brain itself may also cause a gradual reduction in the number of these nerves. So this is a concept to help our patients with in understanding progression. So it isn't related to brand new areas of inflammation as relapsing remitting multiple sclerosis was, but rather a gradual loss of nerves in the brain and the spinal cord. Exactly what causes it is not known at the moment. It is related to the inflammation that people sustained at the first stages of their multiple sclerosis. It's obvious right from the start of multiple sclerosis, but actually the longer you have multiple sclerosis, the more this becomes the predominant way in which people with multiple sclerosis experience their disease. Any questions about that section? Okay, well, there's plenty of time at the end for lots of questions. So let's look at what we can do about it. So there's no point sort of making these diagnoses, upsetting people, upsetting the apple cart, turning up late for your lunch, if there's not something practical that you'd be able to do about it. Of course, Lisa's a statistician, so she would like to know look, could it have been predicted? Could it have been predicted that Lisa would go on to develop secondary progressive multiple sclerosis? She says, look, I know a lot's changed since I was diagnosed, and are you any better at predicting those patients who would develop secondary progressive multiple sclerosis now? And we went back and had a look at some of the scans that Lisa had done. So this was her initial scan at the time of diagnosis. And of note, she's got 2 contrast-enhancing lesions at that scan that she had at the time she had her optic neuritis. We then looked at her scans at year 1 when she presented with that episode of disturbance in her legs. And she had a number of new lesions, including a new brainstem lesion and a new spinal cord lesion. Actually, a number of studies looking back at what happens to people with multiple sclerosis have identified some things that can help predict from the early stages those patients who develop secondary progressive multiple sclerosis if they weren't treated. So this is an untreated cohort. But particular things in those early scans that indicate a higher likelihood of developing secondary progressive multiple sclerosis are gadolinium-enhancing lesions, particularly more than 2. 1 or more new spinal cord lesions at a time of a follow-up scan at 1 year, and 1 or more new lesions within the brainstem at a follow-up scan for the year. And these things are quite powerful. They all act together. So if you have none of those things and you have a new diagnosis of multiple sclerosis, it's about 1 in 20 chance that if you weren't treated, you'd go on to develop secondary progressive multiple sclerosis at 15 years. Actually, if you have all of those things, you have a 85% chance of developing secondary progressive multiple sclerosis if you weren't treated. So that's about 17 out of 20. This is an untreated cohort, so that's not necessarily the case in modern UK MS practice, but it's a useful talking point to help patients to understand the sort of risks and benefits of their treatment. So we say, well, look, yeah, it could have been predicted. Not at the time, we didn't know this, but modern data has provided us with some factors that can help us predict this. So Lisa says, well, look, would that help you decide what to do back then? And I think it does. So this is data from the MS-based registry showing that if you're started on a treatment, even glutamin acetate and beta interferon, you're much less likely to develop secondary progressive multiple sclerosis. And probably if you use a more highly active treatment, that's even more apparent. And actually, if you're going to use a highly active treatment, some other studies suggest that it's worth starting it sooner. So this is looking at people who switch to a highly active treatment either within 2 years from the onset of their multiple sclerosis or more than 4 years, 4 to 6 years after the onset of the multiple sclerosis. They diverge in their disability, so those people who started on the highly active treatment are on the blue line, and they're less likely to get disabled over time. But actually, when you look at year 6, so at this point, everyone's on the highly active treatment. Those people in blue who started their highly active treatment earlier were less likely to progress in their level of disability than those people who started late. So it does seem that using medications, using them early, and using a highly active medication early do reduce the risk of disability progression. All of that, I don't know if that's nice for Lisa to know, that things are better for patients now, or that she's missed out on something. It's not quite clear. But she says, look, what do we do now? And actually, before 2020, it wasn't a very good thing to do to diagnose someone on treatment with secondary progressive multiple sclerosis, because the funding criteria said that the medicines had to be stopped at a diagnosis of secondary progressive multiple sclerosis. After 2020, there was a medicine called saponamod available for people with secondary progressive multiple sclerosis. The criteria for this were initially a bit difficult to operationalize. You had to have increase in disability progression, but you had to have either a relapse or MRI disease activity on treatment, and lots of people on treatment didn't have that. That changed in late 2022, and if you were progressing on your treatment, and they define that as an increase in your EDSS score, a level of your disability score, due to progression without relapses, you could switch to siponimod. So that would be an option for Lisa. Why do we switch? Why do we think about using siponimod in people with secondary progressive multiple sclerosis? So this is data from a trial called the EXPAND clinical trial, which compared disability progression in people who were given siponimod compared to those people given placebo. So you want to be as low as possible. You want to be along the bottom. So those people given siponimod are in blue. Those people given placebo are in grey. What do you guys think about that? Do you want to be on the blue line? You sort of want to be on the blue line, but it's... You don't really want to be on either of those lines, do you? you just want to be along the bottom. So yeah, Lisa says, look, I definitely don't want to be on that grey line, but I don't really want to be on that blue line either. It still looks pretty depressing, doesn't it? That inexorable increase in disability. And actually, we probably need to think a little bit differently about medicines for progressive multiple sclerosis than we do medicines with relapsing multiple sclerosis. So this is looking at the proportion of people who need a wheelchair, adjusting for baseline EDSS, and you're about a third less likely at 3 years to need a wheelchair or to go to a stage where you need a wheelchair if you're given siponimod as compared to placebo. But what you can do is you can stretch that line out. You can guesstimate as to what happens much further in the future. And when you do that, it seems that starting siponimod and carrying on with it for 15 years reduces that point at which you need a wheelchair by 4.5 years. And that can be a bit more an impactful way to think about the rather boring treatment that you have to take every day that you notice no benefit to and is a hassle to you and is a hassle to monitor. Of course, the onset of progression is another opportunity for us to review all the support that we give to patients with multiple sclerosis. And these are all the other ways in which, and I know I don't have to tell you this, the other ways in which we can help people. And often the onset of progression, people's needs do change. It is worth referring to people like physiotherapy, occupational therapy, social worker, looking at treatments that we give, symptomatic treatments of pain, spasticity and depression, looking at neuropsychological support for the cognitive symptoms people have, trying to, again, make attempts at optimizing brain health, weight loss, smoking cessation, healthy living, the opposite of heavy living. Looking at other things that we can help, function electronic splints, Botox, baclofen pumps, helping people at work, helping people access to work is a lifeline for lots of patients who start to get mobility problems that will pay for a taxi to people to go from work, and also supporting people with employment issues and medical retirement. So what can we do about secondary or progressive multiple sclerosis? Well, actually, we can now predict those patients who are much more likely to have a progressive disease course in time, and those sort of things are spinal lesions, contrast-enhancing lesions, new spinal cord lesions, and brainstem lesions at year 1. You probably can prevent progression or delay progression by using early use of disease-modifying therapies, particularly highly active disease-modifying therapies early in people's disease progression. But often we don't have the liberty of those things, and people are coming to see us who already have progressive multiple sclerosis. You can help people. There are medicines available. Those medicines do require some different thinking about outcomes. You don't feel better straight away. The medicine is a hassle, and you're doing it for your long-term brain health. And progression is also a prompt for us to think about all the other ways in which we can help people with multiple sclerosis. And it's an opportune time for people to have assessments back with physiotherapy, occupational therapy when they've been discharged. Any burning questions about that section? We'll move on a little bit, and I'll take you now. We're at the limits, so this is at the limits of knowledge. And I'll take you through some modern understanding of actually what is progression, when it occurs, and what we can do about it. And I'll introduce you to a concept called, or if you don't already know, called progression independent of relapses. I'll take you through a case. So this is Scott. He is 43. He's very busy. He's very active. He's very clever. He's another He's got a PhD as well. He's very into his figures. And he had a left optic neuritis. His MRI scan showed some contrast-enhancing lesions, and his lumbar puncture showed presence of oligoclonal bands. So we were able to give Scott a diagnosis of relapsing remitting multiple sclerosis with a single relapse. And Scott says, well, you know, that's great. I now know what is going to happen to my life, what my future entails, and I need you to tell me exactly what is going to happen to my multiple sclerosis and how, if it is at all, things are going to get worse. And actually, you don't really need to tell me, because a few years back I watched one of the talks that you gave to the medical students, and I know this is what happens in multiple sclerosis. So I've been diagnosed with relapsing remitting multiple sclerosis. So this is what's going to happen to me. I'm going to have a relapse, which I've got better for. I can expect further relapses in time. Maybe in some of those relapses, I won't completely recover. My baseline will be a bit high. I'll be left with some permanent symptoms, but those symptoms won't change over time. They won't get worse. And actually, I've got 10 to 15 years to not worry about anything until I reach the secondary progressive stage of multiple sclerosis. And at that stage, my disability is just going to increase like this. But yeah, it's 15 years away. I can wait till I'm 60 till I need to worry about that. Is that true? Does that fit with your experience? So it doesn't fit with your experience, does it? You don't have to look after many people with multiple sclerosis to realise that this graph doesn't really fit what you're seeing. But it was actually only in the last few years that this has been recognised as a concept. So this is a study looking at a number of Novartis studies that are performed into people with relapsing remitting multiple sclerosis. And to get into these studies, you had to have a diagnosis of relapsing remitting multiple sclerosis. And these were studies, so they were strict on that. So they looked at 27,000 patients. Over that time, they had about 15,000 relapses and about almost 200,000 times where people's level of disability went up or down. And let's look at what Scott was thinking about was going to happen to him. So you come for your study visit, and I ask, have you had a relapse? And Scott says, yes, I've had a relapse. And we do his level of disability assessment, and it's gone up. And that relapse was in the last 90 days. And then we follow Scott up 3 to 6 months' time and sort of see how you are. He says, well, I haven't had any other relapses. We double-check he hasn't had any relapses before or after. But his level of disability is the same. He's got a bit better, but he's still above his baseline. And that's called relapse-associated worsening. When they looked at that big data set of what happened to all those patients, they did find quite a lot of relapse-associated worsening, almost 500 times that happened in the data set. So this definitely does happen to people with relapsing remitting multiple sclerosis. My slide to the medical students was correct. But Scott and I read the paper a little bit further, and they also introduce a concept called progression independent of relapses. So this is someone who comes along for their study visit, a little bit like coming to see you in clinic. You ask them, have you had a relapse? Have you had a relapse? I really need to know for the study. If you don't tell me about relapses, the study makes no sense. Have you had a relapse? And they say, look, I definitely haven't had a relapse. So no relapses within the last 90 days. But you measure their level of disability, and it's gone up. It's gone up. And you check again. You check in 3 to 6 months to make sure that it isn't a quirk, that they didn't have a bad day, that something else wasn't going wrong, that you put it in wrong. And it's up, or it's even worse. And you just check at that time. You ask them again, you haven't had a relapse recently? No relapses recently. And then you phone them up a month later and say, hey, you haven't had a relapse? It wasn't a relapse that was sort of in the midst when you were seen last. And they say, no relapses. And we call that progression independent of relapses. So you've asked that patient on 3 different occasions if they've had a relapse. You've told them it's really important, it's part of the trial. If they don't tell you the truth, it makes the trial worthless. And they said no. But they have got worse. They've progressed without relapse activity. And actually, in that group of people with relapsing remitting multiple sclerosis, that's twice as common. So you're twice as likely to get more disabled because of progression independent of relapse activity, rather than relapse-associated worsening with relapsing remitting multiple sclerosis. And lots of these are quite hard to assess. And this isn't especially rare, so about 1 in 14 patients with relapsing remitting multiple sclerosis in this cohort got worse every year, and about half of them had a progression independent of relapse activity. So this is a bit of a nightmare, isn't it? These people, they come to clinic, you ask them if they've had no relapses, or you phone them up and they say, look, I definitely had no relapses, but they're getting worse. Is there anything that we can do about it? Is there any point even knowing about this because we can't do anything about it? Well, actually, progression independent of relapse activity does also seem to be amenable to treatment. So this is data from Italy, looking at patients who were treated and those who weren't treated. On this graph, you want to be along the top. That's no progression. And those patients who were treated in green were much less likely to progress than those patients who were not treated in red. And the treatments that you're on seem to matter. So progression independent of relapse activity is less common in more effective treatments. So this is data comparing ofatumumab to teriflunomide. And progression independent of relapse activity is about half, or just under half, as common in those patients on ofatumumab as compared to teriflunomide. There's very similar data looking at this with ocrelizumab compared to beta interferon and alemtuzumab compared to beta interferon. So more effective treatments do seem to prevent progression independent of relapse activity. So look, I hope in this point I've shown you, introduced this new concept to progression independent of relapse activity. It isn't just an academic point. This is the main reason that people, even at the early stages of relapsing remitting multiple sclerosis, get worse. It occurs really early, so it occurs at this really early stage when people are treated. It is a bit of a nightmare because it's hard to detect. You can only really detect it if you are either doing EDSSs or you're inquiring carefully as to whether patients are having any progression in their symptoms, which I'm sure you'll be able to do now. But you can help prevent this by using disease-modifying therapies, and it does seem to respond or be better suppressed by those disease-modifying therapies that are highly effective. So, any questions? Any questions on things?